Hi, good morning to one and all. Today's lecture topic is immediate dentures. Okay, coming to the learning outcomes. So, by the end of the lecture, you should be able to identify the importance of immediate denture, categorize the types of immediate denture, recall the clinical and lab procedures involved in fabrication of immediate dentures. Okay, and outline indication, contraindication, advantage, disadvantage of immediate denture. Okay, coming to the introduction. So, following extractions, the remaining dentition, which cannot be rehabilitated, patient suffers from social indigeneity and functional difficulty of going without teeth for weeks. So, immediate denture comes into play here, and it's the best choice for when the last hopeless teeth are to be removed and the patient can be spared of any embarrassment of not having any teeth. Okay, so coming to two types of immediate denture. So these are the types. This is the conventional immediate denture and interim immediate denture, CIDIID. Okay, so conventional immediate denture is after placement of immediate denture, it is relined and refitted to serve as a long-term prosthesis. Okay, this is the most commonly one which is done. Interim immediate denture is also done, so it enhances the aesthetic stabilization functions for a limited period of time. It can be done in between, maybe like a FPD or maybe implant placement, right? Like in a young patient with like a single teeth missing. So we have done this type of things in our department. Yeah. Okay, coming to Jiffy denture, this is one type of interim immediate denture. Okay, so basically everything is the same. All the things are same as an immediate denture, except that the denture teeth are made with the tooth colored autopolymerizing acrylic resins. Okay, this is not done now very frequently. It used to be done before. Okay, so you can see that the indications are like mutilated teeth, uh, teeth which cannot be rehabilitated, it the teeth which have hopeless prognosis, they cannot be periodontally treated. They are having grade 3 mobility. Occlusal plane is gone. There is no attachment remaining. There's too much attachment loss. Okay, so these are basic indications which a person would be going for an immediate denture. Okay, basically a person who will be requiring total extraction and then can get immediate denture fabricated if he has certain social concerns or aesthetic concerns. Okay, coming to the contraindication. So, uh, uncooperative patient with poor general health, poor surgical risk, multiple extractions may cause complications systemically, are contraindicated. Of course, psychological disorder patient won't be able to handle that. Sorry. Okay, so anterior undercut. Um, the ridge may interfere with the impression procedure. Yes, because it's like a freshly extracted socket, which is not compressed in a total form. You understand? So yes, undercuts can create issues. Presence of remaining teeth at different positions. Yes, this seen frequently in patients with different occlusions and mobilities and grades of different level and attachment losses. Yes, this is seen. May lead to incorrect recording of the centric relation in video. Yes, you have to make sure and correct this step. You have to be careful, rather. Inability to establish a try-in stage. Yes, this is really hard to establish and it cannot be done basically. Okay, more chairside time, additional appointments. Yes, additional appointments is a problem, of course. Temporary impairment of speech and mastication. Yes, initially the patient will have problem, later patient will adjust. Wound resorption, shrinkage of unhealed soft tissues greater and faster, may require frequent relining. So yes, in some places the resorption shrinkage of the unhealed soft tissues can take place. So yes, require a storyline later. Okay, coming to the diagnosis and treatment planning and prognosis. So this treatment planning and patient education is really meticulous. It has a lot of clinical performance, which sorry, has to be aided by careful use of tissue conditioners and sorry, and it will ensure a predictable treatment outcome for most of the conventional immediate dentures. Okay, so a well planned and monitored uh, conventional immediate denture can serve as a definitive processes for a long term. So I have done one case in my MDS times, and yes, the patient had used it for a long time. I had to reline it, I think, twice, but the patient was happy and she was using it. She was a young patient. Okay, so coming to clinical and lab procedures. Okay. So first visit will be first extraction or surgical visit. Okay. So you can see whatever teeth are supposed to be extracted first will be extracted. So this will be done in sectional form. Okay. So of course, sorry, before extraction there will be oral prophylaxis, and then whichever teeth are supposed to be extracted first will be extracted. So extraction would probably start with the posterior teeth. Okay, the primary impression diagnostic cost. Okay, so after extraction of whatever posterior teeth which we are supposed to go, we will take an impression and pour a cast. Okay, and take a bite. A single full arch custom tray or two stage custom tray. Okay, so this is usually done when the interior teeth are still remaining. So yes, you have to block out all the interior teeth like we do. Whatever teeth are there, we're supposed to block that out. Then you can have the stop effect. You can have stops also placed there. It can be 2 to 3 mm short of the vestibular roll, the vestibular depth, you can say. And of course, created by a resin tray. It has to have a handle, it has to be bottom molded, and an elastomeric impression has to be taken after that. Okay, so you can see these. Okay, so first of all, it has been covered, okay, blocked out, and the spacer has been made. Of course, stops are made, and special tray with the handle is. Okay, so coming to two tray or sectional custom impression tray. Two trays are been used. First you outline the borders, use melted wax, or allow the melted wax to flow and cover basically the undercuts. The autopolymerizing raising should be used to cover the posterior edentulous areas. It can be used, guys. Okay, so anterior can be done with or without the tray. Posterior sectional tray is tried in. Okay, so you'll understand better when I showed you. Okay, so this is the anterior tray, the posterior tray. Okay, it can be tried in with or without. Okay, so you can see this is without the anterior impression, this is with the anterior impression. Okay, all right, it's taken by help of this tray. All right, so these are two trays which are using this full tray. Okay, this is one other alternative to use a two-step tray. Okay, so it's like a putty index which also can be used as an impression together with the light body impression. Okay, all right, this is how it looks like. All right. Okay, coming to the jaw relation record. So an evaluation of the patient's existing VDR, the vertical dimension has to be done. Undercut should be blocked out, and occlusal rim is supposed to be made. Yes, retromolar pad is taken as a guide. This is, guys, following the complete denture principles. Recording by opening, uneven tooth loss, video must be closed because of the drifting and exclusion of the the posterior teeth. So guys, we will have to establish a VDR and VDO. Yes. Okay, of course, if you are doing a Facebook transfer in a semi-adjustable articulator, then this procedure will come into play. Otherwise, we are not doing it. Okay, so you can see few teeth are remaining. We have created a nice gap so that the tray comes out easily and there's no undercut. There are record base. There are occlusal rim. Okay, so that's how it looks like. It's still the depth, of course. Okay, so now he's just putting it in the mouth, establishing the VDR, checking it, establishing VDO, taking a bite. Okay, all right. So that is the jaw relation. Now, setting denture teeth and trine. So in the conventional immediate denture, the posterior teeth are missing. So trine can be done even. Yes. So in that case, trine can be done. Yes. Because some teeth are still present, guys. Okay, so arrangement is according to the centric occlusion. Okay, so trine is done, lower cast is remounted if required, guys. Okay, so whatever cast is required, it can be remounted. Patient's aesthetic desired can be confirmed. Midline has to be checked. Anterior occlusal plane, interpupillary guideline, everything has to be followed and checked. Okay, so you can see that there's a bite being taken, and anterior teeth trine can be done. Okay. Otherwise, these are the bite blocks for taking an occlusion. Okay. So now we have to see the high lip line. How's the lip line? We're supposed to arrange and do the teeth setting according to that. We have to give characterization of the midline rotation. It can be discussed with the patient. Vertical, anterior vertical, and a horizontal overlap, which enhances the aesthetics and phonetics, also has to be taken care of. Then the tooth modification has to be re-evaluated for occlusal plane or centric relation. Okay, cast will be marked with all the findings of the initial intraoral examination. Okay, so everything will be marked and okay, now coming to the teeth arrangement, the lab phase. Okay, so now you mark an X on the tooth to be removed, or just mark it, and with a saw or a cutting disc, you just trim off the. Okay, and we have to try and maintain a concave, surface. Okay, so yeah, trim the extraction side with a carbide burr. Yeah, and maintain a proper concave ridge. The facial portion can be trimmed conservatively to the pocket depth line. Okay, so this also can be dealt with properly. This one, yeah. So, uh, in our trine, you can just what do you call, mark the smile line, right? Incisal edge, where is exactly supposed to be. This is where the extraction is going to take place, and we have done one side, and then you can check that. Oh, here is the correct uh, what do you call, lines are coinciding properly or not with the actual standards. Okay, so the lingual and the palatal tissue should be trimmed because they will collapse to a pocket depth after extraction. Okay, so these have to be trimmed off. Okay, so if you're doing an overdenture, the abutments have to be 3 mm above the gingival margin. Okay, so that also can be done. The intercanine distance should be noted and, used a gauge and measured and kept. Okay, so you can see that this was removed and the tooth placement was placed. Okay, so first doing with the interior, and then probably what do you call, removal of the posterior, and then doing the full denture step by step. Okay, so trimming the cast. So the rule of the thirds are suggested by Kelly. So it recommends dividing the labial aspect of the ridge into three equal bands of space between the gingival line and the depth of vestibular space. Okay, so this all has to be done. Trimming the labial portion of the cast begins from the labiolingual center of the ridge and is confined to the gingival and middle third. Okay, so most of the trimming will be done in the gingival third. The lingual portion of the cast is contoured, smoothened, and again placed and smoothened again by starting at the labiolingual center. Okay, so you can see they're just showing you the guide of how can you trim. Okay, so starting from here. Okay, and then you'll trim a little bit. Okay, you can just appreciate the photos. Okay, coming to this region, and then smoothening out the concavity. Okay, so wherever the level of the teeth are, you can see how you can trim off, because this is also a very important step. So because we are creating an edentulous space on the cast. Okay, all right. So the extent to which the cast is trimmed, where it is reduced, a bone height with the recession of the gingival tooth. So if there's a recession, okay, so this would be the bone height. Okay, if the recession is somewhere here, this is the bone height. So you have to just, again, the extent to which the cast is trimmed when there is a bone, when there's a loss of bone height without recession. Okay, so there might not be recession here. You can see that the gums are also recessed down here. Only the bone is recessed down. That means there should be a pocket depth. Okay, so it's just giving you a guide till where do you need to make a trim of the teeth in the cast or make it edentulous. Okay, coming to the wax contouring, flasking, and boil out. So thickness of acrylic resin is needed to provide room for trimming. And so boil out is dewaxing, guys. Yeah. So, yeah, sorry. So we have to relieve any sore spot. A remount cast to preserve the face bow should be done for reevaluation after 2 to 3. Okay, if you're using a semi-adjustable article. If you're not, again, a reevaluation has to anyway be done. So a flasking is done in a similar manner as a conventional complete denture. Okay, or any characteristics to be present on the denture, you can do it during the wax up. All right, coming to a surgical template. So yes, surgical templates are also made. So according to Farmer 1983, surgical template is a thin transparent form duplicating the tissue surface of an immediate denture, is used as a guide for surgically shaping the alveolar process. Okay, so it can be used as shaping the edentulous ridge. Okay, so because you're trying to make a dentulous cast edentulous, you're supposed to have concavity throughout, and this can be helped and used as a, okay. So steps of fabrication. So we are here talking about steps only to fabricate a surgical template. So alginate impression at the time after dewaxing of edentulous ridge is taken. Stone model is poured. So clear resin template on this duplicated casts are made by four methods: vacuum form method, sprinkle on technique, and processed by template in a clear acrylic. Okay, that is the wax up, flasking, or heat processing, and even a light clear acrylic can be used. Okay, so this clear acrylic can also be used. Okay, so these are the four methods. Okay, now processing and finishing of the conventional, sorry, the CIDs, that is the conventional, sorry, excuse me, conventional immediate dentures. Okay, so processed similar to the complete denture are the CIDs. Okay, so if a desired lab remount can be done, it should be done. Okay, so lab remount, when we covered the last lecture of relining, rebasing, and denture repair, we had talked about it. Okay, guys, so lab remount can be done. It's a way of relining, rebasing our denture. Okay, so we have to preserve the undercuts area of the denture slightly thick to allow the insertion over the undercuts. Okay, so again, you have to just be careful around the undercuts. Okay, and you have to have a straight line path of insertion, otherwise you will not be able to fit in the prosthesis. Posterior undercuts can be retained as they provide an alternate path of insertion and withdrawal. Yes, it can be. So these two concepts can come in use in certain cases, not all the cases. So these things can be done too. Okay, any bumps inside the dentures should be relieved. Yes, obviously, and to allow the convex healing. Okay, so both denture and surgical templates should be placed in a chemical sterilization solution in a bag for delivery. Okay, so anything sterilized before using, because we are basically dealing with some amount of blood in the mouth. Okay, if not too much, a little bit here and there. Okay, so coming to the surgery and the denture insertion. So over denture abutment reductions can be done, sectioning of the FPDs, extraction of remaining teeth to preserve the labial plate of the bone. So these are some ways to preserve the bone. Okay. Okay, and surgical template is used to do some adequate bone trimming, and it should be in contact with all the tissue surface. Okay, of course this can be checked and used for trimming. Sutures, where required, should be placed. Okay, foil can be used to protect the extraction site while reducing the, or denture abutment. So this one is basically is for the over denture. Okay. Okay, pressure indicating areas should be trimmed. Okay, obviously, these things have to be trimmed. Uh, Denture heel areas are checked for interference. So wherever it's, sorry, the spelling is wrong, guys. Sorry. Wherever it is like healing, any interferences, any extra tissue, anything has to be taken care of, and the counterpart in the denture has to be checked and trimmed off. Okay, occlusal prematurities are to be corrected if any. Okay, high points basically are to be checked. Phenol has to be relieved. Inadequate retention may require reline with the tissue conditioner for the time being, and then with the permanent relining material. Trim of any projections can be done. Okay. Okay, coming to the post-operative care and patient instructions. So, of course, we have to do a recall in the first 24 hours. So, we should advise the patient not to have hot liquids, alcohol, and do not keep rinsing. If you keep rinsing, you are going to dislodge the clot, so don't do that. And first 24 hours, do not remove the denture, as it will form a clot, of blood, and things should be okay. If the patient keeps removing, there will be bleeding, and patient will not be able to wear it back. Okay, ice pack for 20 minutes has to be put on inflammation, swelling, and discoloration. Premature removal denture, of course, will be very hard to be reinserted, so no, patient should not touch it. Patient education about pain, extraction, and removal of the denture should be given. Antibiotic regimen has to be prescribed after 24-hour visit. Ask for patients sore spots, any sore spots which are appearing to be such color strawberry red, that is like the bright red. Spots canine on near the canine eminence, any lateral tuberosities, posterior limit areas, retromyloid undercut area, anything has to be trimmed off, has to be relieved basically. Okay, so any gross occlusal discrepancies has to be adjusted, it has to be evaluated for attention. Okay, now first, after the first operative, post-operative week recall, so you have to counsel the patient to wear for 7 more days, and see how things work. After 24 hours, patient should be taught about removal, reinsertion of the denture. Okay, so the patient should be able to rinse at least 3 to 4 times to keep the extraction sites clean. Yeah. After 1 week, sutures can be removed, and patient can begin removing the dentures at night. So first week after post-operative is usually the normal denture issue instructions we give to a patient after 1 week in a conventional denture. Okay, but yes, there is an extraction socket to be taken care of. Okay, and if any antibiotic regimen has to be continued, it should be. If not, then then it should not be required. Okay, so guys, that is it. Coming to the summary, immediate dentures fulfill an important role in today's treatment modalities by providing the patient with aesthetics, function, and psychological support after extraction and during the healing phase. The technique is more demanding than the regular complete dentures for both the patient and the dentist. If the patient is well prepared and the appropriate type of immediate dentures selected, the resulted processes can be successful. So basically, guys, if done well, the patient will be satisfied. But yes, the problems are triumphs are not possible in all the type of cases, and most of the cases, and A relining has to be done. Yes, patient comfort is there at some point, but slowly things can go down better with the patient, and we're always there to help the patient. So uh, things can be done from the dentist side, and but patient has to be very well informed about this immediate denture concept and has to be told about advantage, disadvantages, problems they're going to face, and everything. Because later it gets a little difficult to deal with the patients. Okay. Okay. All right, guys. So thanks so much for patient listening, and let me know if there are any questions. I am always in Polyclinic 3, Prosto Lab. Prosto department, let me know, come and talk to me, read about this, and you can refer to any of the complete denture textbooks for this. Okay. Yeah. Thank you.